Okay. 5, 4, 3, 2, 1. We all are live now. We can start the session.
So hello all, good evening all. So we are going to start Fishbowl, PG Fishbowl session and the master class. That is the preferred practice pattern on chemical injuries, cornea, retina and glaucoma. We are going to start our second, third and the fourth JHOS Fishbowl, PG Fishbowl session by the Jharkhand Ophthalmological Society. And I'm very confident that this focus priming on chemical injury and cornea will not only strengthen the fundamentals of our postgraduate students, but also empower them to actively engage, think critically, and derive maximum benefit from the upcoming fishbowl session. So now I invite Dr. Bhaarti Sharma. She is the head of the cornea services of Manipal Tata Main Hospital, Jamshedpur, for a quick introduction of postgraduate students, the inner circle and the outer circle. So over to Dr. Bhaarti Sharma, madam.
Yeah, thank you, ma'am. So welcome everyone for this fishbowl session on chemical injury. So quick introduction, we have a lot of postgraduate students with us today. And from the inner circle, we have Dr. Sonia Ghosh, Dr. Shrishti Shreya. They are both from Rio Rims, Ranchi. From MGM Medical College, Jamshedpur, we have Dr. Amar Kumar, Dr. Mayank Saran, Dr. Vikas Thakur. From our own Tata Main Hospital, Jamshedpur, we have Dr. Richa Tiwari, Dr. Sana Afreen, Dr. Bhavya Chaudhary, Dr. Raksha. And from CCL, Gandhinagar Hospital, CCL Ranchi, we have Dr. Lalita Priya, Dr. Firdos Jahan. From Bokaro General Hospital, we have Dr. Nupur Gupta, Dr. Hospital. Yeah, sorry, I just was interrupted in
Your
between.
voice
So,
is
Kashyap
breaking.
Hospital, we have Dr. Neeraj Jha and Dr. Sakshi. So, coming to the outer circle, we have from Rio Rims, Ranchi, Dr. Anamika Chaudhary. From Bhagwan Mahavir Manipal Hospital, Ranchi, we have Dr. Pooja. Dr. Nidhi Sharma is from MGM Jamshedpur. Dr. Anamika Thakur, Bokaro General Hospital. And Dr. Ujjwal is also from Bokaro General Hospital. From Kashyap Memorial Eye Hospital, Ranchi, we have Dr. Gagandeep Singh Gulati, Dr. Shubham Singh, Dr. Ishaq.
Okay. So, madam, you are not audible.
It seems that her connectivity
sorry,
is
ma'am.
little poor.
Am I audible now?
Yes,
Yeah, better, much better, yes.
So I welcome everyone. So to the session, let us start the session, please. Thank you so
much. Before that, I will request everyone to open their window because we have to take the pictures. Please open your window. Premlata, please capture. Please open your window. Because for each session, we have to take pictures.
Dr. Bhaarti, am I visible?
Yes, yes.
Thank you.
So, Dr. Neha Chaudhary, are you here?
Yes, ma'am. Yes, ma'am. I'm here.
Okay, सब अपना window खोलो. Photo हो गया. So first we will take up the case of Dr. Neha Chaudhary, 5 minutes, and then Dr. Vatsala Kuwar and inner circle, outer circle, whosoever will be the best. We will be giving every session cash prize 1,000 rupees. And Dr. Shweta Walia and all the guest faculties will decide who is the best discussant of the session. So one discussant from this session, chemical injury. We have 2 presenters. Madam Premlata, have you taken the screenshot? Okay, please start.
Yes,
Neha Chaudhary, over to Neha Chaudhary. Carbide gun injury.
Yes.
Please share your screen. Neha, please share your screen. Yes.
Yes, ma'am. Can I start, ma'am?
Yes, fast. 5 minutes.
Good evening, everyone. I am Dr. Neha Chaudhary, from second year PG resident from MGA Medical College. Today I am going to present my case. A 17-year boy from Jamshedpur came to emergency department of our institute with chief complaint of blurring of vision in left eye for 2 hours and burning sensation in left eye for 2 hours. My patient presented to the emergency department with chief complaint of blurring of vision and burning sensation in left eye following an accidental blast from a calcium carbide toy gun used as a firecracker. There was no history of insect entry. There was no history of installation of eye drop for long term, and there was no history of ocular surgery or contact lens use. In the treatment history, the history of prior ocular irrigation at home with tap water was done, and there was no history of use of any ocular or systemic medication before hospital presentation. In past history, there was no history of chronic illness and no history of autoimmune disease. In family history, there was no significant history. In personal history, my patient was a student. He had a mixed diet and normal appetite, and there was no history of drug allergy and no history of tobacco and alcohol consumption. In general examination, my patient was conscious and well oriented to time, place, and person. His vitals were stable and pill code was normal, and he was afebrile at the time of the presentation. In ocular examination, in general, the head posture was erect and the facial symmetry was symmetrical. In external examination, the visual acuity of the left eye, the uncorrected visual acuity was 6 by 60 and the best corrected visual acuity was 6 by 24. The IOP of the left eye was 14 and the extraocular movement was full and free in all cases. In slit lamp findings in left eye, in eyelid and adnexa, there was a diffuse lid edema and eyelashes burn and first degree burn over periocular skin. In conjunctiva, the subconjunctival hemorrhage was present nasally from 9 o'clock to 11 o'clock, and there was a diffuse conjunctival congestion. In cornea, the central corneal epithelial erosion of 5 into 5 mm diameter was present and corneal haze was present. The fluorescence stain was positive and the limbal ischemia present from 6 o'clock to 8 o'clock, which was less than the 3 o'clock hour involved. In anterior chamber was normal in depth and quiet, and the iris was brown and regular, and pupil was normal in size and reactive to light. These are the images. The first image which shows the central corneal epithelial erosion of 5 into 5 mm diameter, and the fluorescence stain was positive. And in the second image, we can see that there was a diffuse lid edema and eyelash burn and the periocular skin burn. And the third one is the slit lamp cross-sectional image in which we can see the corneal haze. In fundoscopic examination, the right eye and left eye fundus was within the normal limit. In systemic examination, there was no evident findings were present. My differentials were chemical injury, thermal injury, and toxic keratoconjunctivitis. The blood investigations were done. The following investigation were done, and the B scan of the left eye was done, which reveals a clear anechoic vitreous cavity. The retina is attached throughout. There was no vitreous opacity, RD, and choroidal abnormality, and the lens was in the position. Case summary. A 17-year male presented to the emergency department with complaint of blurring of vision and burning sensation in left eye after an accidental blast from calcium carbide gun, and there was no history of ocular surgery, contact lens use, and no history of long-term installation of eye drop use. On examination of left eye, the uncorrected visual acuity was 6 by 60, the best corrected visual acuity was 6 by 18, and there was a diffuse lid edema, eyelash burn, and primary burn over the periocular skin. And there was subconjunctival hemorrhage and diffuse conjunctival congestion. Central corneal epithelial erosion of 5 into 5 mm present. Fluorescence stain was positive. Limbal ischemia was present. And the anterior chamber iris pupil were normal. And the fundus was within the normal limit. My final diagnosis is left eye chemical thermal injury by calcium carbide under modified Roper Hall grade 2 and Duas grade 2. The management in emergency under topical anesthetic ocular irrigation was done with 2 liter normal saline using IV set, and then by double everting and upper eyelid and the lower eyelid, particular materials and debris was removed and trimming of the burned eyelashes were done. The medical management in left eye, eye drop prednisolone acetate 1%, 1 drop 6 times a day given. Eye drop moxifloxacin 0.5%, 1 drop 4 times a day given. Hometropin eye drop 2%, 1 drop 3 times a day given. CMC 1 drop 4 times a day given. and eye ointment azithromycin locally application at night, and eye ointment D panthenol locally applied thrice daily. Tab vitamin C 500 mg, 1 tab twice daily for 10 days, and tab doxycycline 100 mg, 1 tab twice daily for 1 week, and follow up that after 3 days. In first follow-up visit on day 3, in left eye, the uncorrected visual acuity was 6/18 and best corrected visual acuity was 6/12. IOP was 11 and the extraocular movement full and free in all cases. In eyelid adnexa, eyelash burn and first degree burn over periocular skin present, subconjunctival hemorrhage was present, diffuse mild conjunctival congestion present, corneal opacity 5x5 mm, fluorescence stain was negative, and the limbal ischemia present, AC was quiet, and pupil was dilated pharmacologically. In treatment part, the same medication was prescribed, which was prescribed earlier, and follow-up done after the 3 days. In the second follow-up on day 6, the patient was symptomatically better. In the left eye, the uncorrected visual acuity was 6/9 and the best corrected visual acuity was 6/9. The IOP was 11 and the extraocular movement was full and free in all cases. In conjunctiva, there was a mild congestion. In cornea, cornea was clear, fluorescence stain negative, and there was no limbal ischemia. AC was quiet, and pupil was dilated pharmacologically. And then in treatment part, the eye drop prednisolone acetate 1% frequency was tapered, 1 drop 4 times a day. And after that, after 1 week, 1 drop 2 times in a day. And after 1 week, 1 drop 1 time, and then stopped. And other medication were continued for next 1 week. This is the Roper Hall classification that we used while grading. And this is the DUAS classification, which we also use. And in our case, it was DUAS grade 2. And this is the pathogenesis of calcium carbide ocular injury. In pathogenesis part, when calcium carbide comes in contact with the water, it will form acetylene gas and the calcium hydroxide. And as we know, the acetylene gas is a highly inflammable gas, which will cause the thermal injury. And the calcium hydroxide, which is a strong alkali, it will cause saponification of cell membrane. Due to that, the hydroxide ion will enter into the cornea stroma and cause collagen and proteoglycan degradation. And the following cascade will happen, and it will cause a limbal stem cell deficiency, and it can cause corneal melting and persistent epithelial defect. And this is the chronic sequelae that can happen, like corneal opacity, corneal neovascularization, symblepharon, dry eye, secondary glaucoma, cataract, and corneal perforation. So the take-home message, as we know, the calcium carbide gun injuries are complex and highly eventful. They are tripartite injuries, which consist of mechanical, thermal, and alkali injury. So prompt copious irrigation is the most critical vision-saving intervention. And we should always suspect the open globe injury, intraocular foreign bodies, and multiple tissue involvement. And the limbal ischemia and the degree of the ocular surface damage are the key predictors of the long-term visual outcome. And these injuries are severe and yet entirely preventable through the public awareness and safety education is needed. Thank you.
Thank you, Dr. Neha, for wonderful presentation. And you can stop sharing your screen.
So Dr. Varsha, Dr. Shweta Walia are the expert panel for this.
Yeah, please go ahead.
So before we start the discussion, I would request all the inner circle and the outer circle residents to ask questions that are pertinent to the case, not just theory, the clinical relevant questions, because we are having a cash prize for the best discussant. So let's start the discussion. And
after this discussion, we will take the second case, right?
Yes.
Yes.
Okay.
So who is going to put up the first question? Dr. Amar Kumar, Dr. Bhavya.
Yeah, good evening, everyone.
Amar, yes.
So in medical management, as we see that you use corticosteroid eye drop. So if patient has still ongoing ocular surface inflammation, then what we should do? Should we continue the corticosteroid eye drop or should we stop the corticosteroid eye drop?
Actually, we give a corticosteroid to reduce the inflammation. So we will continue the steroids.
So anyone would like to counter the answer of Dr. Neha? Is it correct? Dr. Amar, what do you think? How long the corticosteroids need to be continued and when they should be stopped? Dr. Amar, would you like to highlight?
Yes, ma'am. Yes, ma'am.
Yes,
Corticosteroid eye drop should we stop? Then we should add some topical preservative-free lubricants to continue and taper it as the duration increases.
So very correct. We need to stop steroids after 7 to 10 days, irrespective if the inflammation is there, because collagenase activity starts after that, and there can be corneal melting if we continue with the steroids. So, thank you, Dr. Amar. Dr. Bhavya, would you like to ask any questions to Dr. Neha?
Dr. Shweta, if I may interrupt at this point,
Yes, we can, but actually the experts have to answer after at the end, once the discussion is completed by the residents.
Okay, sure.
First, the inner circle, outer circle, they complete their discussion.
So by that, we come to know what is their take on the knowledge, how well they have taken up the chemical injury part in any case.
Anamika, Vatsala.
Yes, ma'am.
Yes, Dr.
Good
Anamika.
evening, ma'am. Just one thing I want to know, that you mentioned that the best corrected visual acuity was, I guess, 612 or something around. So is it what is the rationale behind taking the BCVA when there's a 5x5 mm epithelial defect? And I think I just wanted to know, because according to the studies, and they say that it is not advisable to take the BCVA just immediately, because the vision deteriorates in the later phases. And also with such epithelial defect, patient will have a associated photophobia, watering, so the refraction is not possible, or it's a bit difficult to do at that stage. So was it the pinhole vision or the actual refractive vision?
It was a pinhole vision.
It was a pinhole vision, not the refractive vision. So you need to mention that it was a pinhole vision. Anyway, very good presentation. Thank you.
Thank you, Dr. Anamika.
And what was the rationale behind using azithromycin ointment or the D-panthenol ointment?
Like azithromycin, like it will help to inhibit the metalloproteinase enzyme, so it will effective in collagen synthesis, as it is a anti-cholangiolytic substance.
Okay, and anti-glaucoma medications were not added?
Were not added because IOP was within the normal limit. That's why it was not added at that time.
Okay. Thank you.
Thank you, Dr. Anamika. Anyone else from inner circle? Dr. Lalita, Dr. Mayank, Dr. Neeraj would like to ask the question? Dr. Firdaus? If there is no one from inner circle, we'll move to the outer circle. Dr. Sakshi, are you there, Dr. Sakshi?
Yes, ma'am.
Yes, please. You want to ask something? You are gone muted again.
No, ma'am.
Okay, so the inner circle has no questions to put to Dr. Neha. Let's move on to the outer circle, who are the second years and the third years. Dr. Anamika Thakur, Dr. Gagandeep, Dr. Shubham, who is going to put the question to Dr. Neha? I think everyone is satisfied with your presentations and there are no questions to you. Anyone?
Actually, it was a good presentation with details.
Yes, the details, and she had added the theory part also, and
Yes,
that's
yes.
why it's all complete.
So
Yeah.
Anamika Chaudhary is from outer circle.
Yes, she was from outer
So
circle.
yeah, Amar, Anamika, they answered well, participated well. So should we take up the next person?
No. I have a question to ask to Dr. Neha for the knowledge of all the PG students. Everybody is mentioning you irrigate and irrigate and irrigate. How do you irrigate, Neha?
So we will use the hypertonic solution like
No. How do you do? Tell me the procedure. What do? You don't put a glass of water and put it on the eyes. Of course not. So what do you do that?
Connect the IV set to the NS or to the RL bottle, and we will irrigate from medial canthus from the medial towards the lateral canthus, and also we will double evert the eyelids for, and also irrigate in that area also. We will also irrigate in fornices, both in upper and lower eyelid, and we will continue it for about 30 to 60 minutes, and approximately according to books 3 liters fluid should be used, and in every 10 to 15 minutes pH should be checked, but in our center, as we know, the litmus paper was not present in emergency department, so we didn't use that in that time.
Got it. Seema, tell me one more thing, just one more question.
Yes.
Do you tell your patients what will happen after the irrigation? No. So there's going to be a lot of chemosis after you irrigate, with such a lot of irrigations. This is just for your knowledge. You get 100% marks from me. Fantastic.
Thank you,
Madam,
Dr. So can we take the expert comment and then we can move on to the
next
second
speaker.
Yes.
Firdaus, you are asking something, Firdaus?
So, ma'am, about topical steroids, actually, we don't stop them after 7 to 10 days these days because active ongoing inflammation is actually a cause for non-healing epithelial defects. So, we actually continue that. It is true that presence of an epithelial defect will lead to underlying melting of the stroma. But if the inflammation is not taken care of, your defect is actually not going to heal. So we continue the steroids. We don't stop them after 7 days, 14 days, which was like a concept which was previously practiced. But these days we continue the steroids, and depending on the severity of the injury, actually we would start them even 1 hourly for some patients with a grade 6 injury and then taper them off weekly. You can give oral doxycycline, tetracyclines for the collagenollytic, anticollagenollytic effect. So that is one thing that I wanted to highlight, that steroids are important in the acute phase. And if the effect is not healing, find out the cause why it is not healing. If it's a grade 6 injury, if there is an ischemia, it will not heal. So unless ischemia, your defect is not going to heal. If the pressures are on the higher side and if you're not adding an AGM, your defect is not going to heal. So there are multiple other factors which also need to be looked at.
Thank you, ma'am.
Thank you. You are an ocular surface person in the Ascent. So naturally, we are going to listen to you and follow you. So the message is the longer period, especially if the injury is deeper. Okay. So let's move to the next speaker, and Dr. Varsha.
Good evening, everybody.
Good evening.
So is my slide visible, ma'am?
Yes, yes.
So I'm going to present on chemical injury of the eye, and my guide is Dr. Rahul Prasad, sir. 29-year-old male, driver by occupation, resident of Ranchi, came to the emergency at 9 p.m. after chemical injury in his eyes from his bike's battery splash with a complaint of burning sensation in both the eyes since 12 hours, pain in both the eyes, watering in both the eyes, and redness in both the eyes since 12 hours. History of presenting illness. My patient sustained a history of chemical injury from a fluid that splashed from his bike's battery on his face and eyes 12 hours back. He complained of burning sensation in both the eyes since 12 hours. It was associated with diminution of vision, which was sudden in onset and painful. It was also associated with watering from both the eyes, photophobia, and redness. He washed his face and eyes with tap water and went to a local eye hospital in Ranchi. There he was examined and was diagnosed with both eyes corneal abrasion with limbal damage. He was prescribed some topical and oral medications and was referred to the higher center for further management. For this complaint, he visited our hospital. Past ocular history, no significant ocular past history. Past medical and surgical history, no significant history, and no significant family history as well. The personal history, patient has normal appetite, normal bowel and bladder habits, no addiction to any known substance. Social history, he belonged to lower middle socioeconomic group. General examination. Patient was alert, conscious, cooperative, and well-oriented to time, place, and person. Patient was of average build, fair in nutrition. The vitals, the temperature was, if he was afebrile to touch, the pulse was 66 beats per minute, blood pressure was 110 by 70 millimeters of mercury, and respiratory rate 16 cycles per minute. No sign of pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema were noted. Systemic examination was within the normal limit as far as the cardiovascular system, respiratory system, central nervous system, and the gastrointestinal system was concerned. Ocular examination. On ocular examination, for the right eye, his uncorrected visual acuity was 624, and for the left eye, it was 618. There was no improvement. Globe position and size were normal. For the eyelid and adnexa, the lid swelling with upper eyelid abrasion was seen in the right as well as the left eye. For the right eye, the conjunctiva had chemosis with diffuse congestion and stain was negative in the conjunctiva. For the left eye, the chemosis was diffuse with congestion. Staining was present in the medial half area. Cornea epithelial defect, which could be seen as 10 into 8 mm. And for the left eye also, the epithelial defect was seen 7 into 7 mm. Limbal staining was absent. The anterior chamber had normal depth. The pupil were normal in shape, reactive to light. The lens were clear, and the IOP measured by NCT at 9:30 p.m. were 14 and 16 millimeters of mercury. This is the picture of the right eye and the left eye, showing corneal staining 10 into 8 and 7 into 7 millimeters. On fundoscopy, the media was hazy. The optic disc had normal shape, normal color, CDR 0.4, margin well defined, and the neuroretinal rim was healthy. Same for the left eye. The blood vessels, normal in caliber, arising from the central disc, dichotomously branching with the AV ratio of 2:3. Macula, the foveal reflex could not be visualized due to hazy media in both the eyes, and the periphery was within the normal limit. So this is the Roper Hall grading, which take into account the limbal ischemia and the corneal involvement, and it has 4 grades, 1, 2, 3, and 4. And the prognosis is good in the first 2, whereas it is guarded in the third and poor in the fourth one. For the corneal involvement, first has epithelial damage, second has haze, but the iris details are visible, and the limbal ischemia is less than 1/3. For the third grade, the corneal involvement is total epithelial loss with haze that obscures the iris details, and the limbal ischemia is 1/3 to half. And the fourth grade, cornea is opaque with iris and pupil obscured, and more than half limbal ischemia. Case summary. A 29-year-old male presented to the emergency with a history of chemical injury in the eyes by bike's battery. He complained of burning sensation in both the eyes since 12 hours, associated with pain, watering, redness in both the eyes. Systemic examination was normal. His best corrected visual acuity was 624 in the right eye, 618 in the left eye on day 1. On anterior segment examination, he had abrasion and swelling of both the eyelids, chemosis with diffuse congestion in both the conjunctiva. Stain was positive on the medial side of conjunctiva in the right eye. Epithelial defect was seen of the cornea, 10 into 8 in right eye and 7 into 7 in the left eye. The IOP was normal in both the eyes. On fundoscopy, the media was hazy. The FR could not be appreciated. Rest was within normal limit. My differential diagnosis is acid chemical injury and the alkali chemical injury. Since he got splashed from his bike's battery, so it is H2SO4. So we take the provisional diagnosis as acid chemical injury. Both eyes grade 1 acute acid chemical injury according to Roper Hall classification. Management and treatment: thorough wash with appropriate 10 liters, there's a misprint, 10 liters of ringer lactate was done in both the eyes of the patient as soon as he came to the emergency, and then his vision was taken and slit lamp examination was done after this, and eye drop prednisolone acetate 1 drop was prescribed in both the eyes, 1 drop 2 hourly for 2 days, followed by tapering dose. Eye drop moxifloxacin 1 drop 4 times daily was advised. Eye drop polyethylene glycol 1 drop 1 hourly. Eye drop homatropin 2% 1 drop 2 times. Eye drop chloramphenicol and polymyxin B were asked to be applied at bedtime. Tablet vitamin C 500 milligram 4 times a day for 14 days, and tablet esflurfenac serratiopeptidase paracetamol SOS basis, and tablet pantoprazole empty stomach, so that he can take all these medications. Patient was called for review daily for 6 days and then on the 15th day. So this is the follow-up on the 6th day. As we can see, some SPKs are still, we can see in the right as well as the left eye, and mild lid abrasion was also present in both the eyes. Rest, everything was within normal limit, and this was on follow-up 17, and everything came back to normal, and patient is currently under observation and on monthly follow-up. Thank you.
Thank you, Dr. Vatsala, for excellent
So over to the Dr. Shweta Walia, our moderator.
Thank you, Dr. Bhaarti. So the case is open for
everybody. Please open the window because we have to take picture.
It is also better to interact when the videos are on. So who is going to ask question to Dr. Vatsala? Dr.
Inner circle.
Dr. Nupur, Dr. Lalita, Dr. Mayank. Who is going to ask?
Inner circle.
Good evening, everyone.
Yes.
So, ma'am, as seen in slide that subconjunctival hemorrhage or subconjunctival chemosis is present. So, how will we differentiate between true limbal ischemia or subconjunctival hemorrhage or chemosis between them, and how our treatment differs when you know is it true limbal ischemia or subconjunctival hemorrhage or chemosis?
Okay, thank you for the question, Dr. Amar. So when it is limbal ischemia, on a slit lamp examination, that the sclera is completely white because the blood vessels are not able to go there. As far as when there is hemorrhage, subconjunctival hemorrhage, redness would be seen beneath the conjunctiva, and for the chemosis, the swelling of the conjunctiva could be seen.
And how treatment differs when we know that it is true limbal ischemia?
Yeah, so once we diagnose it as true limbal ischemia, if the ischemia is in little clock hours, we'll just observe. But if it increases, we can do tenonplasty, as Varsha ma'am already said, so that we can gain back the blood supply.
Yes, thank you.
So wonderful, Dr. Vatsala. Anyone else from inner circle who wants to ask question to Dr. Vatsala? I think your presentation was self-sufficient and they don't have any questions. Anyone from outer circle? Dr. Firdaus, Dr. Sonia, Srishti,
Dr. Irshad. मतलब सब तुम्हारे सामने फेल हो गए, किसी के पास कोई क्वेश्चन नहीं है,
कोई झगड़ा करना चाहता ही नहीं है.
Yes, Dr. Nidhi, you want to ask something, please?
Yes.
Ma'am, I want to ask why did ma'am didn't use Dua's classification and she just used Roper Hall classification for grading the chemical injury?
No, actually, Dr. Nidhi, I used both the classification. I just showcased the Roper Hall classification. According to both the classification, the injury was grade 1. As far as the Roper Hall classification is concerned, the limbal ischemia and the cornea is judged, whereas for Dua, the conjunctival involvement and the limbal ischemia is judged.
Okay, ma'am. And ma'am, the EPICS classification which has recently been it is better than Dua's classification, ma'am, in what respect?
Because it takes into account 4 things. Apart from the epithelium that we already take into account, we take into account the pressure and EP, I, and X. The exposure and the I is, I am unable to recollect. Is it IOP?
Ischemia.
Ischemia.
Yes, ma'am. Ischemia.
Good. Anything
Okay.
else, Dr. Nidhi? Okay. Anyone else?
Yeah, I want to ask a question. Hello.
Yes, Dr. Ajay. Yes, yes,
Yeah.
yes.
I want to know if a patient came with a chemical injury. So we see first the nature of injury, how much ischemia is there, and most important is the epithelial defect. The area of epithelial defect, whether it is recovering or not. So frequent follow-up is also important. The most important, what she forget to tell, if a 55-year-old or aged patient come with chemical injury, the most important investigations should we do before starting this treatment. So let me know what important investigation, systemic investigation should we ask. Like we start systemic steroid or topical steroid. So better to investigate blood sugar and systemic parameter, whether all these parameters are okay or not. If we start steroid in a diabetic patient, so the condition may become hell. Number one. Number two, the amniotic graft, we use amniotic graft that depends on the severity of limbal ischemia. So it should be ideally placed within 7 days, within 7 to 10 days of injury. So this is also very important.
Thank you, Dr. Ajay, for your inputs. Anyone from inner or outer who would like to ask? So let's move on to the expert comments. Dr. Varsha, please give your experts comments for the presentation and the questions.
Very nice presentation, Dr. Vatsala. The one important point that you highlighted was that the vision and the slit lamp examination is done after irrigation. So that is actually practically very true. When a patient comes to your emergency room with the complaint and when you suspect that it's a chemical injury, you do not, you actually go and irrigate, remove off any inciting agent and then actually examine the patient. Another important point, when you are irrigating, it's a very painful procedure. So always anesthetic, topical anesthetic solution is applied, and
फिर खत्म हो गया.
it's a very painful procedure. So 5 to 10 times probably putting topical, even while you are irrigating topical anesthetic solution, it actually helps the patient. I would have liked it if you would have given a Dua's classification, and more if you would have given an EPICS classification, because in practical practice as of today, we do not follow Roper Hall as such. It's more of a theory basis that if you want to put a grade, Roper Hall grade 3, but it actually we do not follow Dua's, and more recently some centers follow EPICS. I would like to know this. The question is open to everybody, to all the PJs. What are the when there was a classification which is a Roper Hall, and from there we shifted to Dua's and now recently to EPICS. Why is it so? What are the cons of these classification that are taken care of by the subsequent classification? Like why you follow Dua's and not Roper Halls? If anybody can tell.
Ma'am, because it takes into account the IOP and the ischemia.
No, that is the EPICS classification. I'm speaking about Duas. So what is it that Duas has an advantage over the Roper Halls?
Ma'am, more superior because of predicting the surgical outcome. Because it involves it to give information about the conjunctival involvement.
Yeah, true. But the two cases that Dr. Vatsala and Dr. Neha presented, both of them were grade 1 Roper Hall, grade 1 Duas, and grade 2 Roper Hall and Duas. So the grading in that 1 and 2 was the same. So the prognosis is also almost the same. So then how Duas is better than...
Actually, for the fourth classification of Roper Hall, the dua take into account as fifth and sixth. So that makes the difference.
Exactly. So what was seen was that grade 4 of Roper Hall, all the cases that fall into grade 4 of Roper Hall actually do not have same prognostication. It actually depends on many other factors. And that's why Dua classified them into 4, 5, and 6. So 1, 2, 3 remains the same mostly. It's the 4 that has been subclassified into 4, 5, and 6. And what does Duas take into account? Limbal ischemia?
Limbal involvement and conjunctival involvement.
Conjunctival.
Roper Hall takes into account limbal ischemia
and cornea.
Limbal defect. While Duas takes into account a limbal defect also. Even if there is no limbal ischemia, it is graded as limbal involvement, which is more prognostically predictive of the futuristic limbal stem cell damage. What EPICS, obviously, I think I would have highlighted, so you would be able to answer, is that EPICS takes into account more than the conjunctival involvement and the defect. It's